We're going to move to our last speaker, last but not least, of course, Dr. Mohamed Shakir, Professor of Interventional Radiology at Ain Shams University, and he's an expert in geniculate artery embolization. He will talk to us today. His presentation is about geniculate artery embolization for knee osteoarthritis. Thank you.
Thank you, Dr. Ahmed. Good afternoon. So talking about this technique, geniculate artery embolization for knee osteoarthritis. As you know, osteoarthritis is the most common degenerative joint disease, and it is the main cause of chronic pain and disability in elderly people. It affects about 40% of men and 47% of women. Pain is the main symptom in knee osteoarthritis, and it is the main target to alleviate also, as it leads to limitation of the knee joint movement and reduced quality of life. We have many modalities for treatment of osteoarthritis according to the stage of osteoarthritis, from mild up to severe. According to the stage, we start with a lifestyle modification, followed by pharmacological treatment, and then local injections and neurotomy. And then in the advanced severe cases, we need total knee replacement. And although we have all these modalities of treatment, but there is a gap in the patients who are not responding to the non-surgical treatment, and at the same time, they are not candidates for the total knee replacement. So we need another technique or modality to fill this gap. And we can fill this gap with the geniculate artery embolization, which was proposed by Okono et al. In 2015 as a minimal invasive treatment for knee osteoarthritis. And to know why we use geniculate artery embolization in knee osteoarthritis, we need to know what is the pathogenesis of the knee osteoarthritis. Actually, it was thought to be a wear and tear disease. It's no longer known to be wear and tear disease. Actually, this is an inflammatory disease of the synovial joint, of the knee joint. So starting with genetic and environmental risk factors as aging and biomechanical stress of the knee joint, this starts the degradation of the articular cartilage and inflammation of the synovium of the knee joint, and this leads to new angiogenesis produced by the inflammatory cytokines in the knee joint, and this new angiogenesis brings more inflammatory mediators to the knee joints, leads to more inflammation, and the more inflammation leads to more degradation and more angiogenesis and so on, so forming a vicious circle. Also, new angiogenesis leads to growth of new unmyelinated nerve fibers, leading to sensory new innervation, which is the cause of pain in such cases. So by geniculate artery embolization, we target this point, which is the new angiogenesis, to cut or break this vicious circle and alleviate the pain and stop the inflammatory condition. We should know some anatomical considerations, specifically the arterial supply of the knee joint. Knee joint has about 7 arteries supplying the joint. The most important is the descending genicular artery arising from the distal segment of the superficial femoral artery, and it gives 2 branches, the superficial or saphenous branch, which is a cutaneous branch, and the articular branch, which is the main cause of the inflammatory blush in about 2/3 of cases with knee osteoarthritis. We have also from the popliteal artery the superior lateral genicular artery and superior medial genicular artery. We have the middle genicular artery, the inferior lateral genicular artery, the inferior medial genicular artery, all of these from the popliteal artery. And also we have the recurrent anterior tibial artery coming from the anterior tibial artery. Each artery of these have its own territory at the anterior surface and or anterior aspect and the posterior aspect of the knee joint, and we always correlate the complaint of the patient. We ask the patient where is the points of maximum pain and correlate it with the possible artery supplying this area. So how to do the technique? First of all, as we said, we ask the patient, where is your pain? And we palpate the knee joint, where is the point of tenderness, so that we can expect before doing the technique what is the artery supplying the area of the inflammatory plush, and we can put a marker, as you see here, over the suspected area of the inflammatory plush. And then we do our procedure as routine as any embolization technique, femoral access under local anesthesia. And then we do catheterization of the superficial femoral artery by the Mater catheter, usually 4 French catheter. And we can go, by the way, either crossover technique from the contralateral side or antegrade technique from the same side. And then we can identify the vascular supply of the knee joint and which artery is responsible for the inflammatory plush. As in this case here, we have this descending genicular artery on the medial aspect of the knee joint responsible for this inflammatory plush. And then we do super selective catheterization of this descending artery by a microcatheter, 2 French up to 2.4 French. Sometimes some operators prefer to use a smaller 1.7 French microcatheter, and we try to go as distal as possible. And then we start our embolization procedure very slowly to avoid reflux into any non-target artery. And we'll talk now about the embolizing materials used. And our target is the disappearance of the inflammatory plush with preservation of the parent artery, so that if this patient will go later on for total knee replacement, we preserve the vascularity of the knee joint. And then the routine hemostasis. So regarding the embolizing agent, usually you use particles, and the aim of particles is to do embolization of the small arterioles involved in the inflammatory plush with preservation of the parent arteries. We have 2 types of embolizing materials, either temporary or permanent. The temporary, which is the imipenem cystatin antibiotic, and the permanent, the known particles as the embozine, embosphere, or PVA particles. And the size here is very important, as in any other embolizing technique. For the embozine, we use 75-100 micron. For the embosphere, we use 100-300, and for the PVA, we use 10-70 micron. And actually, there is no statistically significant difference between the different embolizing material regarding the clinical outcome and till now. And there is an ongoing clinical trial comparing the different embolizing material, which is the GO2 study. So how to measure our outcome? To measure the outcome, we look for the technical success rate, the clinical success rate, and complications. Regarding the technical success rate, is measured by embolization of at least one of the arteries supplying the inflammatory plush. May be supplied by more than one artery. If you succeeded to catheterize and embolize one of them, this is considered as technical success. But for sure, if you embolize all the supplying arteries, this will get more or better clinical outcomes. The clinical success rate, the technical success rate, is about 90-100% in different years. Regarding the clinical success rate, it is measured by many methods. The most common of them is the WOMAC score. It is a questionnaire measuring the degree of pain, the degree of stiffness, the degree of physical function. And many studies proved significant reduction in the score of the WOMAC score after geniculate artery embolization, and the reduction of the score started within 1 week of the procedure. At 6 months, there is 80-86% clinical success, and the clinical improvement is durable and continues for more than 2 years in the current studies. Another scale, which is the visual analog scale, which is well known to measure the degree or severity of pain, grading it from 0 to 10 or from 0 to 100 according to the severity of pain, and we measure it before and after the procedure. And again, all studies proved significant reduction in the visual analog scale of pain after geniculate artery embolization. And also all studies proved that the best responders of geniculate artery embolization are patients with mild to moderate knee osteoarthritis, not patients with severe osteoarthritis. As we know, the osteoarthritis of knee is graded from 1 to 4 according to the KL score, or Killigren-Lawrence score. This is a systematic review and meta-analysis including 11 studies, 268 knees with the KL score ranging between 1 to 3. And also it proved significant improvement of the WOMAC score and the visual analog scale, which occurs in about 58% in the first week and continues in 85% over 2 years in both visual analog scale and the WOMAC score. Also, most of the studies proved the significant reduction in use of analgesics, non-steroidal anti-inflammatory, and opioids in such patients. And in a lot of patients, actually, they can stop the medication, especially patients who complain of the knee osteoarthritis as the main cause of pain in the knee. As we know, knee may have other pathologies like the tears and cartilage or meniscal tears. So if patients have mainly knee osteoarthritis, these are the best responders, not patients with the combined pathologies. We can assess the response radiologically by the MRI 6 months after the procedure. First, to assess the synovial membrane and the reduction or the improvement of the synovitis, and also to assess the efficacy or effect of the geniculate artery embolization of the articular surface, if it have negative effect of the articular surface, so that this patient can go later on for total knee replacement or not. And we have 14 points to check in the MRI after geniculate artery embolization, and the most important of them is the assessment of the articular surface and the assessment of the synovium. And most of studies showed that there is improvement of the synovitis in such cases over 1 and 2 years. And so geniculate artery embolization may help stabilize the integrity of the knee joint and the synovium to delay or stop the osteoarthritis progression in such cases. Regarding the adverse events, actually geniculate artery embolization is a very safe technique. No life-threatening complications recorded, such as no severe complication recorded or life-threatening complications recorded. The most common complications are transient cutaneous erythema in 12% of cases, access site hematomas in about 5% of cases, plantar sensory paresthesia in about 1% of cases, mild transient fever in about 0.5% of cases, and all of which are usually self-limited and resolving in about 2 weeks after the procedure. This is our study published at the beginning of this year, including about 16 cases of chronic knee osteoarthritis. And again, we proved that the best responders are cases with osteoarthritis as the main pathology in the knee. There is significant reduction in the visual analog scale and the WOMAC scale. And we concluded that geniculate artery embolization holds promise as an effective minimal invasive procedure for treatment of knee pain secondary to osteoarthritis, and could be introduced as a safe technique with no serious complications. Examples of our cases. Here, a case with inflammatory plush at the medial aspect of the knee joint supplied by the descending genicular artery, and this is after embolization with complete appearance of the inflammatory plush with preservation of the parent artery, and this patient stopped medications. Another case here, also supplied by the descending genicular artery at the medial aspect of the knee joint, and this is after embolization. This is the end point of embolization, which is disappearance of the inflammatory plush, preserving the parent artery. And again, this patient, the main pathology was chronic knee osteoarthritis and stopped medication afterwards. So we followed these patients for 6 months. Actually, this was an MED thesis. So the patient was followed only for 6 months, and no recurrence was recorded in such cases within those 6 months. Another case supplied by the inflammatory plush supplied by the middle geniculate artery, as we see here, the inflammatory plush, and this is again after embolization with disappearance of the inflammatory plush. This is a case with comorbidity of posterior horn median meniscus and posterior horn lateral meniscus tear together with chronic knee osteoarthritis. And again, the inflammatory blush here was supplied by the descending genicular artery, and this is after embolization with disappearance of the blush. And this patient was on COX-2 inhibitors and also with non-steroidal. And after embolization, he depended on non-steroidal anti-inflammatory only. He couldn't stop them due to the tears in the menisci. The embolization of such case needs very minimal amount of embolizing material, maybe half to 1 ml only of the embolizing material. So take-home message. Through embolization of the new vasculature that results from the knee joint inflammation, geniculate artery embolization is used to inhibit the vicious catabolic cycle of inflammation, cartilage destruction, and sensory nerve growth. Geniculate artery embolization has shown its effectiveness and safety as additional option to relieve pain, decrease the use of pharmacologic analgesic agents and injection therapies, and improve functional status and improve the quality of life. Patients undergoing geniculate artery embolization could experience knee joint replacement at an older age, as the procedure has no negative impact on the bone and articular surface. Best candidates and best responders to geniculate artery embolization are patients with KL score 2 to 3, mild to moderate, with isolated knee osteoarthritis without knee joint comorbidity. Thank you very much.
Thank you, dear Dr. Mohamed Shakir, for this nice, illustrative, and comprehensive presentation. I have two questions, if you don't mind. The first question, do you do require MRI for the knee before to decide for this intervention? This is the first point, in order to differentiate whether the cause is meniscus or capsular or any other reason. And the second question is, when does the patient start to feel pain relief after embolization? Does it, is the effect of embolization results in pain relief immediately, or it requires time till the relief of symptoms? Thank you.
Thank you, Professor Dr. Noor, for questions, important questions. Regarding the first question, it is a must to do radiological evaluation before geniculate artery embolization. We routinely do plain X-ray standing for the knee joint to evaluate the degree of chronic osteoarthritis is very important, and also it's very important to do routinely MRI of the knee to assess the internal structure of the knee joint, the menisci, the ligament, and to exclude other main pathology of the knee joint. As we mentioned, the best responders are patients with the main pathology is the chronic osteoarthritis, not other pathology. So this is the first question. Regarding the second question, actually the patients start to feel pain alleviation within few days of the procedure. The first few days there may be some pain due to the ischemic effect, the embolization effect, some cutaneous erythema may occur, and so after these few days, 2 to 3 days, the patient starts to feel improvement of his original pain he is complaining from. Most cases are feeling alleviation of pain within the first week.
Thank you. Wanted to ask you also one more follow-up question. So there is geniculate ganglion ablation also, which
Yes.
is less invasive than doing geniculate artery embolization, obviously. But how does the outcomes of this compare to GAE? That's the first part of the question. The second part would be, when do you choose between both?
When? Sorry?
Do we choose between both? When do you choose geniculate ganglion ablation versus geniculate artery embolization?
Actually, regarding the nerve block, I don't do it, and I don't have experience in such procedure, and I don't know if the literature there is comparative studies between both techniques. For my knowledge, I didn't read something about that, but the main difference between the two techniques is that the geniculate artery embolization stops or breaks the vicious circle of the inflammatory condition of the osteoarthritis. However, the nerve block, it is just a symptomatic treatment. It doesn't break this vicious circle.
So you think it's long-lasting compared to the other one? It is it lasts longer than, because it acts on the pathology rather than the symptoms.
Yes, it stopped the inflammatory condition, so it may be more effective, but there is no comparative studies between them so far.
Okay, for the MRI do you advocate for MRI for every patient before the GAE, or do you rely on clinical presentation and then you move the patients directly to do angiogram, and based on the area of inflammation from the hypervascularity, this is if it corresponds to the area of symptomatology, then you treat accordingly, or do you still get an MRI?
It's essential to do MRI before. Yes, for evaluation, for exclusion of other pathologies. Yes.
Thank you so much. A great presentation.
Thank you.
We appreciate you, and we appreciate all the attendees. And with that, we're going to conclude our session. Thank you so much for attending. Thank you.